we can get started. So I'm going to hand over to Suzanne to start. Welcome, Suzanne, and thank you so much.
Thank you, Felicity, and it's a pleasure to be here today and present to your extended group and others. If we could go to the first slide, that's it. Thank you very much, Nicola. So I'm going to talk about the implementation of natural mutual acceptance across Australia. This is a bit of a historical presentation because I think that's what Felicity put in her requirements. So I've gone back and looked at how we implemented this and some of the steps that we actually followed. The next slide, please. Okay. In the beginning, there was a worldwide shift to single ethics review for multi-site clinical trials. And this was in the EU, where the EU had a directive in 2001, and in New Zealand in 2004, they had a switch to single ethics review. In Australia, in the jurisdictions, there was single ethics review. The first were New South Wales, then Victoria, Queensland and South Australia. Next slide, please. But it was totally restricted at that point, just to within a jurisdiction. So in 2011, 3 jurisdictions got together and we decided to start a cross-border mutual acceptance, and we called it interstate mutual acceptance. And this commenced in October, and it was for clinical trials only. And it was finally superseded by NMA. Now, when we had South Australia join, we actually then badged the whole project as NMA. And this was supported by the Australian States and Territories. At that time, it was under the Standing Council on Health, and it started in 2013. So the next slide, please. And from there, we had regular meetings, but we also asked for representation from all jurisdictions. And this happened quite early in the piece because other jurisdictions that might not yet have got single review could certainly learn from those who had gone through that. The next slide, please. So we had an NMA jurisdictional working group, and this was under the old system of the Australian Health Ministers Advisory Council, a committee, ARMAC, and we reported to ARMAC. The group met monthly to monitor NMA and build further capacity, and continues to do so. And I must say, everyone attends the meetings. It's a really quite good and enthusiastic group. All jurisdictions are represented. The NHMRC and the Commonwealth Department of Health attend meetings as well as observers. So the clinical trials jurisdictional working group and clinical trials advisory committees were part of the whole picture at that time, but that of course now has really changed and it's quite different. The next slide, please. We developed a lot of guidance and information. One of the first was the Nma Brochure. That was quite a short piece, and then just gave a snapshot of what the whole streamlining and single ethics review across the jurisdictions involved. We have standard principles of operation, fact sheets, ethics checklists, various monitoring and reporting framework, and monitoring and reporting tables. These are all available on the jurisdictional websites, which I'll show you later. The other one that's very important is the HREX RGO as an organisation. This gives a list of contacts for researchers who want to have their review done, and they can choose out of the ethics committees listed there which ethics committee they might take their application to. And the next slide, please. The scope and the structure of NMA started off with interventional clinical trials, drugs, devices, radiation therapy, surgery, etc. And also follow-up activities like phase 4, trials were included. So there was one ethical and scientific review, and the review was undertaken by a nominated NHMRC certified ethics committee to review those clinical trials. All sites were required to undertake site-specific assessment, and this was based on the early implementation by other jurisdictions when ethics was single across multi-sites, and then the SSA site-specific assessment was required to inform the sites that don't have any vision of the ethics approval documents, etc. And they can be informed then to do a risk and a management, business management, and other sorts of activities. So the question of indemnity came up. So for commercially sponsored clinical trials, sponsors provide indemnity to the ethics committee that reviews. And this is a standard form with Medicines Australia. Information and data management was done in AU-RED at the time, or any interoperable system, but basically those jurisdictions that started all used AU-RED at the time. And that was linked across the jurisdictions as well. So the ethics application process involved investigators applying to one of these ethics committees using the relevant jurisdictional process and as they were nominated by the jurisdiction. Not every ethics committee in each jurisdiction reviews an NMA. It's a selected number. And they have to be certified by NHMRC. And the selection of that ethics committee is at the discretion of the applicant. And there was a requirement that applications must be prepared on the online information management system and to use the standard ethics application form of the time. Next one, please. And the SSA application process involved each jurisdiction's legislative and policy requirements, and that would be assessed in the SSA form. They're not ethics policies, but other policies that jurisdictions might have. And there was a SSA form for every relevant jurisdiction, and they weren't actually the same form. They were different in each jurisdiction. We had SSA forms for low and negligible risk applications as well, and in Victoria and in South Australia. And of course, the SSA applications had to be lodged on the online information management system so that it was linked to the ethics application, and all data was actually collected on those forms. The next slide, please. So some of the performance metrics included clinical trial sponsor types, that were 79% at that time. Over those years was commercially sponsored clinical trials. Collaborative groups and investigator-initiated were a bit lower, around the 10% mark. CTN applications were about half of the trials at that time, and just one CTX out of 873 trials were submitted. The next slide, please. Some of the other things, the trial phases, phase 1, phase 2, phase 3 is the major activity in that time, 2015. That's actually shifted now. We've got a lot more phase 2 and phase 1 studies as a percentage. The next slide, please. So the performance metrics that we set out with were really around reducing duplication. So at the time, we had 2,325 ethics reviews saved between October 2013 to July 2015. So it's almost 2 years. So that's a very big review burden taken off ethics committees. And if you fast forward to now, where there are many thousands of ethics reviews per year, then you wouldn't be able to imagine how ethics committees would have managed today if they didn't have the single review system. The number of ethics applications was 873 in that time, and we had a 60-day benchmark for ethics review, and that's with a clock on. So it's an administrative estimate because time when the ethics application is out with the reviewer, with the applicant to respond to the ethics committee is not counted. And 85% of the applications were approved within those 60 days, which is a very high performance level. So we're very pleased with those sorts of metrics. Next slide, please. Next slide. Yep, thank you. Yep. So the number of SSAs in that period was 3,198, and 2,300 were authorised. Others would, of course, be authorised subsequently, but there was a cut-off time for the data collection. And 72% of those SSAs out of the batch were authorised in those 2 years. Now I'm going to skip past these graphs. If we could just skip that one, and that one, and that one. Yeah, we'll keep this one. This is again another indicator of how the ethics committees were managing in the NMA, and this is site-specific assessment. So if we turn to site-specific assessment, it was a new process, and it was something that sites had to learn right from the start, whereas if you compare ethics review, there was largely very little change to that. Ethics committees had been reviewing since the 1990s, and they've got the national statement to be guided by, etc. So the ethics committees did have to take on the additional responsibility of having to review for other sites, etc. So apart from that, though, the ethics process was fairly standardised. The site-specific assessment, therefore, was a new process, and we looked at the timelines over 3 years. So from 2012, 13 and 14, you can see that implementation was in 2013 of the first NMA iteration. And you can see the timeline for SSA authorisation has decreased over those years. It really indicates that this new process was probably better understood both by researchers and by the research governance officers at the actual public health services. Next slide, please. So we expanded the NMA scope. This was done under RMAC, and it was endorsed in 2015 and commenced. And we had a memorandum, updated our memorandum of understanding between all the participating jurisdictions. And the other expansion, of course, was data linkage in 2020, when we introduced single ethics review nationally for data linkage projects. Next slide, please. The other change that we had was in 2015 about the research being expanded, not just having clinical trials, but all research projects under multi-site would undergo a single ethics review. So a research project had to be defined, and this is the definition according to the national statement, and that was the definition we adopted. So this really almost doubled the sort of workload, if you like, in the NMA jurisdictions. Next slide, please. So the Nma status in 2021, if we fast forward from 2013 to 2021, in 2013 we had New South Wales South Australia. In 2016, the joining of the Australian Capital Territory, and in 2017, Western Australia joined. In 2021, both Northern Territory and Tasmania Health Departments joined. So we have all 8 NMA member jurisdictions now under the NMA scheme, which is really, really satisfying and great work by everybody. Now, the NMA information for each jurisdiction is listed here. There are the websites for all of those jurisdictions that you can refer to if you need to. And this is also in our fact sheet and in our standard principles of operation as well. And those documents sit on many of these websites as you can access them there. The next slide, please. I just want to make an acknowledgement to all the jurisdictions who have worked cooperatively to achieve the National Interconnected Mutual Acceptance Scheme across Australia. It's been a very, very collegiate working group, and many people have contributed to the what we think is success of NMA, to reduce the number of ethics reviews, to improve the timeliness, and to provide a better service for researchers throughout Australia. And I'll stop there. Thank you.